Diashania. I am a psychiatrist here in Arequipa, Peru. I'm currently working at a public hospital, and my following presentation will be about a case study from this particular hospital. Thank you. No disclosures. Let's start off with an abstract of the case. Childhood and adolescent depression is a recognized clinical entity that produces structural and functional alteration at the neuroendocrine level. Some risk factors are history of depressive symptoms in parents, family breakdown, chronic stressful events, physical, emotional, or sexual abuse. This factor can cause problems with memory, language, emotional, and hormonal regulation. In childhood, depressive symptoms tend to coexist with somatic symptoms because patients often have difficulty expressing their emotion. So these symptoms are a reason for medical consultation. In this report, we will present the case of adolescents with depression associated with galactorrhea, but with prolactin in normal ranges. In clinical case study, the adolescent of 13 years old, high school student who lives with her biological father, her 10 years old brother, and her father couple. She lost her mother at the age of 8 in a traffic accident. After her mother's death, the father devoted himself to the excessive consumption of alcohol and gambling, while the patient assumed the care of her brother. 3 years later, the father started a new relationship, and the woman whom the patient called mom eventually moved in with them. Her stepmother assaulted her psychologically and physically, which caused a decrease in her academic performance, presenting feeling of worthlessness, guilt, somatic symptoms such as headaches and recurrent abdominal pain, insomnia, and passive ideas of death. In the last episode, the patient present oppressive frontal headache, diffuse abdominal pain, predominantly at the epigastrium, nausea and vomiting, reason for which she was admitted in pediatric service. Now let's take a look at the physical exam. When admission, the patient had normal vital function with normal head and breast development. However, she was overweight upon the palpation in epigastric and bilateral positive rhinoureteral point. Pain was observed. The rest of examination was without alteration. She was admitted with the following diagnosis: abdominal pain syndrome, overweight to rule out gastritis, and urinary infection. In addition, in the physical exam, we also conducted an exam. She was evaluated by the psychiatrist in the 9th day of hospitalization. At the mental evaluation, she was found lucid, oriented in time, space, and person, with adequate grooming and personal hygiene. Further observation were inconsistent eye contact, asset mood, depressive, ruminate, coarse thinking, with affective ambivalence toward her father and stepmother, plus unstructured suicidal ideation. The Sum Depression scale was applied with a result of 52 points, which corresponds to moderate depression. The Raven test was additionally paired with results in the 25th percentile, corresponding to a normal low IQ. After we conclude the mental exam, there were additional auxiliary exams. During her hospitalization, an upper endoscopy was carried out. The result of this exam showed an acute gastropathy for which she received treatment with omeprazole. The patient additionally presents a wide, bilateral, and spontaneous discharge from both nipples, which was reported after a week of hospitalization. Antidepressant fluoxetine was administered on day 10 of her hospitalization, which was immediately suspended when the galactorrhea was reported. This auxiliary exam, for example, blood test, prolactin pool, which was repeat, pregnancy, thyroid hormone, estradiol, FSH, LH, growth hormone, ACTH, cortisol, nuclear magnetic resonance of the cella turcica. All the exams were found without alteration. During her stay, the patient received daily psychotherapy, improved her mood and depressive symptoms. She was evaluated by neurology, ophthalmology, and otolaryngology, all of whom concluded the following diagnosis: tension type, headache, amblyopia, and conduct hearing loss due to an earplug. The patient was discharged with 0.25 milligrams of carvedilol weekly and due to state intervention. Her custody was granted in the paternal grandmother. In the control evaluation 1 month after discharge, the patient reported that the galactorrhea had disappeared 1 week after starting treatment. In addition, she reported feeling in a better mood due to her new family environment. And discussion. Galactorrhea is discharged that rise through the canaliculi of nipple outside. Physiology. Child abuse is an environmental stressful factor, and chronic stress can generate neurobiological alteration at the level of the prefrontal cortex, limbic system, and hippocampus that are associated with problems with memory, language, emotional regulation, social, cognitive, intellectual development, and greater psychiatric comorbidity in children's adults. It has been recognized in the medical journal that there are environmental stressors such as child abuse and interpersonal conflict that contribute to the development of mental disorders such as depression and anxiety. And this problem may coexist with somatization disorders such as abdominal pain, nausea, and headache, which affect functioning in children and adolescents. In 1989, reported a clinical investigation of 101 patients who were exposed to adverse events in their childhood. More than half of them present with hyperprolactinemia and or galactorrhea and somatic complaint. Sobrino's research group described since 1992 a model of psychoendocrine interaction and psychosomatic symptoms, found that more than half of adult women who presented idiopathic hyperprolactinemia, prolactinoma, or euprolactinemic galactorrhea, and without being pregnant had been raised by alcoholic parents. In violent environment or absent parents, a situation called paternal deprivation. The relationship was seen in a large population study about 800 people, and it was found again that the presence of paternal deprivation was significantly more frequent compared with control. Adversity and in the first years of life produce change in the brain that modulate the regulation of the hypothalamic pituitary adrenal axis, activating pituitary neurons and lactotroph cells. During psychological stress, there is an increase in adrenocorticotropic hormone, cortisol, and also prolactin, which begin to rise and reach its maximum peak as the end of period of psychosocial stress. With that, we could consider that our patient could present hyperprolactinemia if the psychological stress continued. In our patient, the main symptoms and reason for hospitalization were abdominal pain, episodes of headaches and vomiting. Her family environment was characterized by psychosocial problems. She presented depressive symptoms after the death of her biological mother and somatic symptoms during her cohabitation with her stepmother. During hospitalization, she received psychotherapy, psychopharmacological treatment was suspended on the second day of discharge due to the presence of galactorrhea. Of course, before the administration of the antidepressants, some drugs can cause galactorrhea, such as an anti-dopamine blocker, H2. However, these drugs are associated with hyperprolactinemia, but it was not the case of our patient.